بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على رسوله الكريم سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are continuing the series of gastrointestinal imaging, and we have finished the issue of the esophagus as well as that of the stomach, and now we will continue with imaging of the small bowel. Then you know that the small bowel is imaged by the barium study, which is known as barium meal follow through. And by this examination, we usually let the patient drinks about 200 to 300 milliliter of barium fluid, and we trace the flow of barium through the gastrointestinal tract either under fluoroscopy or by taking serial films to ensure adequate opacification of the whole small intestine, starting from the stomach, ending by the terminal ileum and the ascending colon. Then the patient is usually drinks some of this barium fluid, and the first film will show the stomach as well as the duodenal cap and the duodenal loop. And actually we examine the stomach in a full series like that of the barium meal, hence the name barium meal follow through. Then we after we examine the stomach, we take films, serial films, and the timing between these films depends on the rate of flow of barium through the small bowel, and the usual rate is about 15 to 20 minutes. We take a whole film for the abdomen showing the intestine in sequence, and then you see first the jejunal loops, and the next film will show much of the ileal loops. As you can see here, this is the jejunal loop with characteristic mucosal pattern. Then you can see now most of the ileal loops. Then you continue the examination and taking more serial films until barium is seen in the ascending colon. Then you try to separate the distal ileum and the cecum in a separate spot view like this one, and here you can see this is the terminal ileum and this is the cecum and then the ascending colon. Actually the study is not completed unless you reach the ascending colon, and you can have a good image for the terminal ileum as well as the cecum, as you will see that many of the diseases affecting the small bowel usually affect the terminal ileal loop. Then this was a study done in the era of the barium examinations, and now you know that barium is receding in the face of the modern imaging modalities, but this enteroclysis, or what's known as the small bowel enema, is performed selectively to see some of the small bowel loops in detail, and they examine a certain area with more focusing on the lesion. The examination is done by introducing this very long tube through the esophagus, reaching the stomach, and then the tube is passed through the duodenum, and the accurate position of the tube before injecting barium is usually beyond the site of the ligament of Treitz or in the beginning of the jejunum. And you can see this is the monitoring of the tube under screen control. This is the tube introduced into the stomach, and here the tube is coiled within the stomach, and you correct the position. Then you try again to pass the tube through the duodenum, and finally you reach the this is the tube passing through the stomach, then the duodenum, and it reaches the beginning of the jejunal loop. Then you start injecting barium through the tube. And we supported the barium injection by injection of this methyl cellulose, which is infused at a rate of 100 cc per minute through the tube, also to get a double contrast study of the small bowel. And in a single examination, up to 1.5 to 2 liters of methyl cellulose can be injected together with the barium in order to delineate the whole of the small bowel. You see here is the tube, and we start injection of barium, and you can see the beginning of the jejunal loop. Then if you inject the methyl cellulose, you will see the appearance more better, and this is known as double contrast study of the small bowel. And there is adequate delineation of the mucosal folds as well as the whole segments of interest. And this is also an example. You can see how the mucosal folds are delineated in a better way compared to the injection of barium without methyl cellulose. Then we have some of the notes about the normal figures in the small bowel, and we start by the shape of the mucosal folds. The mucosal folds are more pronounced in the jejunum, as you all know, and they are less pronounced in the ileum. And the fold thickness ranges between 1.8 millimeter in the jejunum and 1.5 millimeter in the ileum. And we consider the mucosal folds are abnormally thickened if the thickness is about 2.5 millimeter or above in the jejunum and 2 millimeter in the ileum. Then the number of folds per inch. In the jejunum, we have about 4 to 7 folds per inch in normal conditions, and there is about 2 to 5 folds per inch in the ileum. And you know that the folds are more prominent, are more numerous in the jejunum compared to the ileum. The fold height. The height of the fold is about 3 to 7 millimeter in the jejunum and 1.5 to 3.5 millimeter in the ileum. Then, considering the lumen diameter, there is gradual decrease in the lumen diameter from the jejunum to the ileum, and the upper jejunum, the caliber of the upper jejunal loops is about 3.5 centimeter, while in the distal jejunal loops is about 3 centimeter, and in the ileum is about 2.5 centimeter. Then you consider that the bowel loops are dilated if it exceeds the diameter of 4.5 centimeter in the upper jejunum, 4 centimeter in the distal jejunum, and 3 centimeter in the ileum. The thickness of the wall is usually judged whenever you can see that there are two bowel loops which are running close to each other or parallel to each other for a distance about 4 centimeter. Then there is a radiolucent line between the two loops. These are the jejunal loops, and this radiolucent line represents the thickness of the wall of that loop as well as the thickness of this the wall of this loop as well. The distance between the two represents the combined wall thickness. Half of this measurement is the thickness of a single loop, and a wall thickness greater than 2 millimeter is considered abnormal. Then, what are the items we would like to discuss in the small bowel? We'll start by the small bowel diverticuli, including also the Meckel's diverticulum, parasitic infestations, one of the most important diseases, which is the Crohn's disease. Then some words about pneumatosis intestinalis and the small bowel ischemia. Then we'll talk about malabsorption syndrome, the small bowel obstruction, and finally the small bowel neoplasms. Intestinal malrotation is usually a symptomatic condition where there is malposition of the small bowel in relation to the large bowel. And in this film, you can see that most of the small bowel loops are located in the right side of the abdomen, while the colon is located on the left side. And this malrotation of the bowel is, as I have said, is usually asymptomatic and is discovered incidentally. Then the small intestinal diverticuli, and you know the GIT diverticuli in general are either true or false diverticuli. The false diverticuli are made only of the mucosa and the submucosal layers, while the true diverticuli are made of the whole layers of the gut wall. Then diverticuli in the small bowel are usually rare compared to the diverticuli in the colon and the diverticuli in the duodenum. And as a general rule, diverticuli have complications which include inflammation leading to diverticulitis, hemorrhage, and perforation, while those in the small bowel may lead to malabsorption and may also lead to intestinal obstruction. Here is a case of multiple small bowel diverticuli. You see this one and this one and this one and a very big one here. And this is a case of a female patient who presented by signs and symptoms suspected clinically to represent malabsorption, and she was treated by antibiotics with mild improvement. This film from this series of the barium meal follow through shows multiple sizable diverticuli in the proximal jejunal loop, and you know that diverticuli may lead to malabsorption because of the accumulation of food and fermentation within the gut, especially if the diverticuli are large. Then this is one of the special diverticuli in the small bowel, which is known as Meckel's diverticulum, and it represents incomplete atrophy of the omphalomesenteric or the vitelline duct. And this diverticulum is present on the antimesenteric border of the ileum. You can see this is the mesenteric border and this is the antimesenteric border. This diverticulum can show the rule of 2, and here is the 2 all through the diverticulum. 2% of the population are affected by Meckel's diverticulum. The diverticulum is present 2 feet proximal to the ileocecal valve. It is 2 inches long and 2 centimeters wide, and there are 2 types of heterotopic mucosa inside the diverticulum, which are the gastric and pancreatic mucosa, and only 2% of the population are having this diverticulum are symptomatic. Actually, you know that identification of Meckel's diverticulum by the ordinary barium meal follow-through and even by the small bowel enema is very difficult, because the diverticulum is small and is usually hidden between the opacified bowel loops. But there are a lot of ways to identify the site of the diverticulum whenever it is clinically suspected, and one of these techniques is to do a selective angiogram of the superior mesenteric artery. Then there will be some blush within the site of the diverticulum because of the vascular ectopic mucosa within the diverticulum itself. And you know that one of the common complications may reach about 40% of this diverticulum is hemorrhage. And that's because the heterotopic gastric mucosa may ulcerate and result in hemorrhage in patients with Meckel's diverticulum. And this is one of the techniques also used to confirm the diagnosis of Meckel's diverticulum, which is known as Meckel's scan. And this is technetium 99M pertechnetate scintigraphy. The isotope is taken by the gastric mucosa, and if you can see a hot spot in the right iliac fossa or in the right lower quadrant of the abdomen, and you can assume that this hot uptake is taken by the ectopic gastric mucosa in the diverticulum itself, and this is can be used to confirm the diagnosis, which is this sign is specific in about 95% in children and 60% in adults. These are the complications of Meckel's diverticulum, which include small bowel obstruction secondary to inflammation, diverticulitis and perforation, and enterolitis, and the development of neoplasia, especially carcinoid tumor. This is a coronal reformatted CT image with oral and intravenous contrast media showing the site of a Meckel's diverticulum, which is inflamed. And you know the inflammation by the obliteration of the diverticulum lumen and the stranding or smudging of the peridiverticular fat planes. Then these are the most commonly situations mistaken for or can produce symptoms similar to Meckel's diverticulum, and especially when it is inflamed, Meckel's diverticulitis. Because of the near location of the diverticulum to the site of the appendix, it may be mistaken for appendicitis or even colonic diverticulitis or mesenteric lymphadenitis or a small bowel diverticuli present other than Meckel's, or communicating enteric duplication cyst and Crohn's disease and sometimes cavitating malignancies. Then we came to the issue of parasitic infection, and this was commonly seen in the previous days or the era of the barium studies, and commonly we can meet many of the Ascaris worms inside the small bowel. And this is the barium meal fall through, showing some of the terminal ileal loops, and this is the terminal ileum, this is the cecum and the ascending colon, and you can easily appreciate these worm-like filling defects within the small bowel representing multiple Ascaris worms. And this is an endoscopic image of an Ascaris worm in the small bowel, and you can see here this is an Ascaris worm in the small intestine as well. And this is a magnification view of some of the intestinal loops showing too many Ascaris worms, and you know that Ascaris worm can swallow the barium, and the barium will appear as an opaque line within the negative shadow of the worm itself. This is a common finding in the barium studies. And the parasites may lead to intestinal obstruction and may also result in malabsorption. One of the parasites also which can be seen in the small bowel is the Tinea saginata, and this worm is very long, as you can see, and if you look carefully here, and you can see a linear filling defect extending through many of the small bowel loops, and it was proved to be due to Tinea saginata. Then we came to one of the very important and one of the commonly seen diseases in the small bowel, which is the Crohn's disease. And this is a chronic inflammatory granulomatous disease of the gastrointestinal tract, and it affects any part of the gut from the mouth to the anal canal. And the most common site of this Crohn's disease is the region of the terminal ileal loop. And this disease is slightly more common in men compared to women, and it occurs at any age, but commonly seen in this age group between 15 and 30 years of old. And the literature consider that Crohn's disease is rare after the age of 60 years. The most important and the most common and the most diagnostic sign of Crohn's disease in the small bowel is affection of the terminal ileum. And the affection of the terminal ileum may have many forms in the barium studies, but frequently it is in the form of a stricture with marked irregular narrowing of the terminal ileal loop. Then the disease, when it is early, it will show some ulcerations in the affected segment with thickening of the mucosal folds due to hyperplasia of the lymphoid tissue. The ulcers are known as aphthoid ulcers, and you remember the erosive gastritis. You can you can see ulcers like this in the stomach in cases of erosive gastritis, where there is a flake of barium which is surrounded by a radiolucent rim representing the mucosal edema. Then the thickening of the mucosal folds, as I have mentioned, is due to lymphoid hyperplasia. Then you can see that the mucosal folds are extremely thickened, and you can see here in this magnification view. Then the ulcers and the damaged mucosa will result in hypertrophy of the normal mucosa to compensate the function of the diseased mucosa, and this will result in polypoid or pseudopolyps, which represent the hypertrophied normal mucosa between the ulcerated damaged mucosa. And the ulcers are usually seen as minute specks of barium coming out from the wall of the narrowed gut. As you can see, this is the terminal ileum, which is markedly narrowed, and you see the fine ulcerations giving the classic rose thorn appearance. And this is one of the common findings in cases of Crohn's disease. Also, what is known as the cobblestone appearance due to hypertrophy of the normal mucosa between the ulcerated mucosa will give such an appearance, which is one of the findings also in Crohn's disease. And you call these pseudopolyps because they are not true polyps, they are mere hypertrophy of the normal mucosa in between the ulcerated mucosa. Then finally, after cobblestone, and you get strictures and narrowing of the lumen, as you can see here. Then this is also an appearance of the terminal ileum, showing the prominence of the mucosal folds, and due to hypertrophy of the normal mucosa between the ulcerated mucosa. And this is one of the appearances of Crohn's disease. You see the terminal ileum is markedly narrowed, and the lumen is severely reduced with minute ulcerations along the wall. And this appearance is usually referred to in the literature as the string sign. And this is the string, and you can see that there is an almost similar appearance of the terminal ileum to this string. And the cause, as I have mentioned, is due to damage of the mucosa, ulcerations, and fibrosis ending in severe narrowing of the terminal area. And this appearance can be also identified on CT scans. You see this is the one of the terminal ileal loops, and you can see the hypertrophy of the mucosa encroaching markedly on the lumen of the small bowel, as you can see here. Then one of the diagnostic criteria of Crohn's disease is the presence of a skip lesion. And by skip lesions, we mean that the disease will affect a segment of the bowel and leave a normal segment, then affect another segment of the bowel. As you can see here in this barium meal follow through, there is narrowing of a segment of the small bowel, and this segment looks to be normal, then there is another narrowing in this area. The skip lesions are one of the characteristics of the Crohn's disease. And Crohn's disease may affect the jejunum, as I have said. It can affect any part of the gastrointestinal tract. And in this case, with the small bowel enema or enterocolitis, you can see multiple strictures. This area, you should remember that in order to say that this is a stricture, it should be persistent in more than one film and one than projection. And this is a stricture, and this is also a stricture, and this is the third one. And in between these structure segments, you can see normal bowel loops. Skip lesions are one of the pathognomonic features of Crohn's disease in the mouth. And here is a list of the complications of Crohn's disease all through the bowel, starting by the stricture, then the formation of abscesses in the adjacent area to the affected bowel loop, also fistulous communication between the adjacent bowel loops, or between the bowel loops and the bladder, or between the loops and the skin, also intestinal perforation, and the intimate relation of Crohn's disease to the development of carcinoma of the small bowel. Cases with Crohn's disease have an increased incidence of carcinoma, and this carcinoma will affect younger patients compared to those with no Crohn's disease. And this carcinoma is usually located in the distal ileum, while carcinomas of the small bowel are usually located proximally in the jejunum. And because it is on top of Crohn's disease, and Crohn's disease usually affects the terminal ileum, then the increased incidence of the carcinoma in the distal bowel in patients with Crohn's disease. And this carcinoma, of course, will develop in areas where the disease is long-standing, and we may have some difficulties to diagnose this preoperative, because carcinoma will result in narrowing of the lumen, and also Crohn's disease will result in narrowing of the lumen, and the difference is not that clear from imaging. This is Crohn's disease affecting the terminal ileum, which is thread-like in configuration. There is marked luminal reduction due to neural fibrosis. And this is one of the complications of Crohn's disease, including fistulae and sinus tracts. And this is the terminal ileum, which is of irregular caliber and irregular lumen as well. Then you can see this track of barium going outside the bowel lumen. And if this is not communicating with any other bowel lobe, and this is known as the sinus tract, but if it communicates with another lumen, then it is known as a fistula. Then here you can see what's known as double tracking, and this is because of the development of multiple fistulae in the region of the in the region of the terminal ileum, communicating the terminal ileum with the cecum. Then we came to the issue of pneumatosis intestinalis, and by this we mean that there is air in the wall of the bowel, And we have two types: the primary type, which is less common, and the secondary type, which is more common. The primary type is seen in about 15% of cases, and there is no relation with respiratory or gastrointestinal abnormalities, is usually located in the colon, and is mostly asymptomatic. Then if you look by endoscopy, and you can feel that these are buckets filled with air, which are closely similar to polypi in the colon. Then this is an idiopathic benign condition, is usually asymptomatic. Sometimes it may be associated with chronic obstructive pulmonary airway disease, and the cysts are usually filled with air, as you can see here, this barium enema, multiple air-filled buckets within the wall of the intestine. Then you came to the secondary type, which is more common, represent or seen in about 85%, and it has a good relation with respiratory and gastrointestinal abnormalities. And this pneumatosis intestinalis, or air in the wall of the small bowel, is usually seen in cases of necrotizing enterocolitis in infants. This issue will be discussed in the pediatric imaging sector. Mesenteric ischemia, strangulation, infection of the bowel wall, and other causes will result in air in the wall of the small bowel, like in cases of small bowel obstruction and connective tissue disease, endoscopy, steroid therapy, intestinal parasites, and in some cases of peptic ulcerations. Small bowel ischemia is due to disturbance of the blood supply, either the arterial supply or the venous drainage to the bowel. And you should know that bowel infarcts or gangrene of the small bowel is difficult because of the extensive anastomosing blood supply. And if there is severe compromise of two of the three major arterial supply, then ischemia and gangrene may result. This may be due to severe arteriosclerosis, as in cases in diabetics, and vasculitis, especially cases of polyarteritis nodosa, and severe hypotensive attacks due to cardiac failure. The common finding of acute ischemia is the presence of prominent mucosal edema, and you see the marked thickening of the mucosal folds compared to the adjacent bowel lobe, which showed normal mucosal fold thickening. And this is also a good example of intestinal ischemia, showing considerable increase in the thickness of the mucosa, as you can see here. Then in chronic cases, there will be mucosal atrophy and narrowing of the lumen, and this is diffuse narrowing of a major sector of the small bowel with a total effacement of the mucosal folds. Then the CT, especially the multi-detector CT, can be of much help to diagnose these intestinal ischemic changes. And in order to reach the diagnosis and conduct the examination in a good way, it's better to give the patient oral water instead of oral gastrografin, and also to have a non-contrast scans before injecting the patient with intravenous contrast. Then inject the patient with intravenous contrast and image the patient in the arterial phase and in the portal phase in order to see the arteries and also to see the veins. Then if you look carefully here, and you see the intestine is filled with water, and you can see some of the intestinal loops showed mural enhancement. These are healthy loops, and the other loops showed no enhancement of the wall, and this is due to ischemia. Then in cases of severe ischemia with impending gangrene, and you see the pneumatosis intestinalis, and you see multiple pockets of air outlining the small bowel loops, which are dilated, containing air fluid levels, denoting the presence of ileus or stagnation. And you can also identify in some cases air in the portal tracts, and this is a very bad sign which carries a greater risk for the patient, and most of these cases usually die. And this is in ischemic changes due to systemic lupus erythematosus, and this is an early stage seen by CT, which is known as the target sign. And this target sign is due to mucosal edema in relation to the ischemia, and you can see the appearance of the thickness or the thickening of the wall, giving what's known as the target sign. Then if you look here, and you can see that the superior mesenteric artery is not opacified like the aorta. The superior mesenteric artery is occluded, and that's why the intestine is dilated, and you see air in the wall of the intestine, indicating that there is some sort of intestinal ischemia. And in this case, you can see air in 3 places: pneumatosis intestinalis, air in the wall of the small bowel; pneumatosis portalis, air in the portal venous tracts; and pneumoperitoneum, air, free air within the peritoneal cavity, and this is usually the sequelae of intestinal obstruction. Then this is a case of small bowel ischemia with dilated small bowel with air fluid levels, as well as air in the wall and air in the portal tracts. And as I have said, this is a very bad sign, and the patient usually dies shortly after admission. And in this case, if you look carefully, you can see this is the superior mesenteric artery, and this is the superior mesenteric vein, which contains a filling defect representing a thrombus. And in the coronal reconstructed image, you can also see the thrombus as a filling defect within the vein itself. And these are the small bowel which are ischemic, and you can appreciate the non-enhancing wall and the relative dilatation. And this is the difference between the viable intestine and the ischemic intestine, and you can also appreciate the thrombus within the superior mesenteric vein. Also here you can see a normal enhancement of the non-ischemic bowel, while the ischemic bowel showed maybe no or faint enhancement of the wall. Then this is also a case of mesenteric vein thrombosis with affection of one of the intestinal loops. You see marked mucosal edema, markedly encroaching and severely attenuating the lumen of the bowel. This is also a coronal reformatted CT image of a patient with a small bowel ischemia. You can see pneumatosis intestinalis and pneumatosis portalis with air in the portal tracts. And this, if ischemia is severe and is not relieved, then these are the sequelae that will happen. Number 1, necrosis of the bowel loop. Number 2, bacterial proliferation in the bowel wall. Gas released in the wall of the bowel. Gas will get into the mesenteric vessels and the portal vein. Then sepsis and intestinal perforation, and finally death. Then we came to the issue of malabsorption syndrome, and this disease was, until now, is usually assessed by the old technique, which is the barium meal photoscope. And of course, most of the cases are not the diagnosis is not reached from the barium meal follow through, but we say that this is a malabsorption syndrome, and that the underlying cause is usually reached by the mucosal biopsy from the intestine. The syndrome presents by mainly diarrhea and steatorrhea with weight loss, abdominal distension, sometimes skin pigmentations, and retarded growth. The malabsorption syndrome, under this syndrome, there are many diseases that are included as causes of this malabsorption. Number one is celiac disease and systemic diseases affecting the small bowel, like the scleroderma, Whipple disease, and lymphoma. Primary small bowel diseases, and these are a lot of diseases including intestinal lymphangiectasia, parasitic infection, intestinal diverticulitis, and blind loop syndrome, Crohn's disease, of course, intestinal TB, mesenteric vascular insufficiency, and eosinophilic gastroenteritis. Also, post-operative conditions like excision of a large part of the small bowel, and the shunting operations between the small bowel loops may result in malabsorption. And we have to say that this sprue is known previously as the original representative or the original description of the malabsorption syndrome. The sprue and the sprue pattern is what is seen through the mucosal biopsy of the small bowel, including flattening, broadening, and the coalescence of the villi, and sometimes complete loss of these structures. And you can see this is the healthy normal mucosa, and this is the damaged mucosa, and you see the degree of atrophy. Similar biopsy changes are seen in the celiac disease of children and non-tropical sprue in adults. And you know that previously we have described what's known as tropical sprue and non-tropical sprue, but you can now describe all these categories under what is known as the celiac sprue. And the celiac sprue will include the celiac disease in children, the non-tropical sprue in adults, and the tropical sprue, which is an inflammatory condition resulting from infection leading to malabsorption. Then celiac disease is an immune disorder caused by eating foods containing gluten, which is derived from wheat. And these are the foods which can cause this disease. This disease will result in damage of the small bowel mucosa, and there consequently be malabsorption of the iron, folic acid, calcium, and fat-soluble vitamins. Then by complications will include strictures in the small bowel, and of course the increased instance of malignancy. In the era of the small bowel barium meal follow through, we have discussed or described some of the signs of malabsorption, which include the moulage sign, the mosaic pattern, the folliculation, and the segmentation. And we used to describe the findings of malabsorption syndrome in the barium meal follow through as dilatation of the bowel loops, effacement of the mucosa, barium dilution, and barium folliculation inside the small bowel. The wide separation of the mucosal folds is due to thickening of the wall of the intestine, and there are effacement of the mucosal folds, particularly in the jejunum, with on the contrary, increase in the number of the mucosal folds in the ileum, and this is known as jejunalization of the ileum. And you see here, you remember from the anatomy that the mucosal folds are prominent and more frequent in number in the jejunum compared to the ileum, and there are a lot of mucosal folds in the jejunum compared to the ileum, but in celiac disease the reverse is seen, and you can see that the jejunum there are few mucosal folds, while in the ileum there are increase in the number of the mucosal folds. Then you remember that I have said that whenever you give barium to the patient, and you can see that the small bowel loops are dilated and the mucosal pattern have changed, and if the barium is not that of good quality, you can see folliculation of the barium inside the small bowel. This is a case of malabsorption, and you can see prominence of the mucosal folds due to edema of the mucosa, and this is what we call the moulage sign, or the folliculation of the barium inside the small bowel. You get segmentation and interruption of the flow of barium through many of the bowel loops, so you cannot judge the caliber, you cannot judge the presence of strictures and so on. Then this is the end of the story, where you can see that the small bowel loops are, the mucosa is totally effaced, and you may get some areas of stricture as well. Then you remember patients with tropical sprue, this is the infection, are treated by antibiotic therapy and folic acid therapy as well, while patients with celiac sprue will respond to gluten-free diet. Then scleroderma is one of the lesions that affect the skin, affect the bones, and affect the gastrointestinal tract. This disease may result in malabsorption whenever it affects the small bowel. And actually, the affection of the bowel by scleroderma will result in some kind of atony and the dilatation of the affected segment of the bowel, together with some prominence of the mucosal folds of the small bowel in particular. But this appearance will simulate many other diseases that affect the small bowel, and the diagnosis of scleroderma is reached by the knowledge that the patient had skin changes of scleroderma and maybe osseous changes of the scleroderma. These are the common radiographic features: delay in peristaltic activity, dilatation of the bowel, commonly the duodenum, and the change of the fold pattern. But in this disease, there is no segmentation, fragmentation, or increased secretion. Then you can see these are the bowel loops affected by scleroderma in the proximal jejunum, as have been said, and you see the prominence of the mucosal folds, and you see atony or dilatation of the proximal jejunum, as well as the duodenal loop is known as megaduodenum. Then Weber disease is a rare infection which affects many of the systems by this bacteria, and it affects usually the middle-aged and elderly males, and is treated by antibiotics and also penicillin. This disease will result in similar features to those have been mentioned with scleroderma. You see dilatation of the bowel loops, and you see the prominence of the mucosal pattern, which is almost similar to this woody wall. And then you can see this configuration of the small bowel is not pathognomonic of Weber disease, but as I have said, some of these diseases the diagnosis cannot be reached unless you have a mucosal biopsy. Then the small bowel obstruction have been discussed in details in the sector of the acute abdomen, but we'll go through about some of the causes. And you know that 80% of the small bowel obstruction are due to mechanical causes, while some of the intestinal obstruction are due to functional ileus of the small bowel. There are congenital causes like jejunal atresia, ileal atresia, small bowel duplication, mid-gut volvulus, mesenteric cysts, and Meckel's diverticulum. And these will be also discussed in full details in the sector of pediatric imaging. Then there are also causes from outside the bowel and causes from inside the bowel. Inside the bowel, intussusception, strictures, and neoplasms like the carcinoma, carcinoid lymphoma, inflammation, especially the Crohn's disease, TB, and ischemia, mural hemorrhage secondary to hemorrhagic disorders, and the overuse of anticoagulant, and foreign bodies like bezoar and gallstone ileus and meconium ileus. And the most important extrinsic cause of bowel obstruction is fibrous adhesion, either secondary to infection or post-operative. Then incarceration of the bowel in hernia or mid-gut volvulus or abdominal masses, and these are many of the causes that result in a small bowel obstruction. And you know, the most important simple radiologic procedure for diagnosis of small bowel obstruction is the plain X-ray of the abdomen, especially in the erect position, where you can identify distension of the bowel by gas as well as multiple air fluid levels. Then the string of beads sign is due to the minute air loculi on the surface of a huge amount of fluid within the obstructed small bowel will give this known as the string of beads sign. And in the plain X-ray, the supine view will show distension, as you can see here, distension of the proximal jejunal lobes by air, and in the erect position you can see multiple air fluid levels denoting small bowel obstruction, especially in the proximal part. And sometimes whenever you can you are unable to obtain an erect view for the patient, then you have this horizontal cross table position where you can also identify air fluid levels in the dilated small bowel. Then, as I have mentioned, that mechanical small bowel obstruction, the most common cause is adhesion, and sometimes the hernia and the volvulus and the neoplasms, gallstone ileus, as well as intussusception. Then, in cases of post-operative small bowel obstruction, you think always of post-operative adhesions, and in such cases, the plain film will show the usual findings, and also the CT scan will show that the small bowel is dilated with multiple air fluid level inside. And this is the case of large bowel obstruction as seen in the erect plain film of the abdomen, showing multiple air fluid levels in the colon. And you can easily appreciate that this is the colon because of the peripheral location and the hostra seen in the CT scan of this patient showed that there is a malignant structure, apple core configuration in the sigmoid colon, which is the cause of this obstruction. Then Crohn's disease, by its inflammatory effect on the bowel, resulting in mural thickening, attenuation of the lumen, and maybe obliteration of the lumen will result in a small bowel obstruction. As you can see, this is the segment affected by Crohn's disease, and the axial image shows distension of the small bowel by fluid, and you can see air fluid levels as well. Then Midgut volvulus is diagnosed by this whirlpool sign, and the root of the mesentery, where the superior mesenteric artery and the vein are present, will show this whirlpool sign. And this is the pathognomonic sign for the diagnosis of intestinal volvulus, and you can appreciate the dilatation of the small bowel with multiple air fluid levels. I will discuss this sign once more in the sector of mesenteric and peritoneal imaging. In gallstone ileus will result from passage of the gallstone into the intestine, and there should be a triad to reach this diagnosis. Number one, you see small bowel obstruction and distension with air fluid levels. Number two, you see gas in the biliary tree, and number three, you can see the stone. And here you can see two of the signs, or even the three signs. The intestine is dilated, the stone is located, and you can appreciate some air in the uh, biliary tracts. This is also a case of gallstone ileus. You can easily see air in the biliary tracts, and you can see a small bowel obstruction with air fluid level, and you can identify the stone within one of the ileal loops. Another case of gallstone ileus, you see air in the biliary tree, and you see dilated small bowel with multiple air fluid levels, and you can locate the stone. This is the triad for diagnosis of gallstone ileus. And you know that bezoar is more common in the stomach than in the intestine, but if it has the chance to pass through the stomach outlet, it may accumulate in the small bowel, as in this case a mass of hair. And you remember, it is known as trichobezoar, can be identified in the small bowel loops. Incarceration of the small bowel in hernia, and this is a common film usually seen in the exams, where the plain film will show dilated small bowel loops distended by gas. This is a supine film. But if you look carefully, and you can see that one of the intestinal loops is crossing the pubic bone, indicating that it is going through an inguinal hernia. Then the CT scan will demonstrate the inguinal hernia and the presence of a dilated small bowel together with mesenteric fat within the scrotum. Intussusception will also be discussed in the pediatric sector, but here is the target sign, which is commonly seen by ultrasound and also seen by the CT scan, characteristic of an intussusception. And intussusception is one of the intrinsic causes of intestinal obstruction. Then ileus is the functional obstruction, and is a common finding in the early post-operative period, but other causes of ileus include peritonitis, hypokalemia, hypothyroidism, and the vascular occlusion. Then this is a plain film in the supine position, and in the erect position you can see some air in the slightly distended bowel loops, and in the erect position you can see multiple air fluid levels. Finally, we came to the issue of the small bowel tumors, and the small intestine accounts for about 75% of the entire length of the gastrointestinal tract. Then the small bowel or the small intestine accounts for more than 90% of the mucosal surface of the gastrointestinal tract. However, the primary neoplasms of the small intestine are very rare and represent about 2% of all gastrointestinal tumors. And also metastases are common in the small intestine than primary tumors. What are the tumors? You can see benign sector, leiomyoma, adenoma, lipoma, and hemangioma. On the malignant sector, you can see carcinoma, the adenocarcinoma, carcinoid tumor, the leiomyosarcoma or the guest tumor, and also lymphoma. And you remember that the duodenum is commonly affected by adenocarcinomas, while lymphoma and carcinoid tumors are usually located distally, except in cases of Crohn's disease, where carcinomas may affect the terminal ileum on top of the pre-existing Crohn's disease. Then these are the clinical manifestations, which are non-specific in cases of cancer: nausea and vomiting, abdominal pain, and melena, and the tumor-related obstruction of the small bowel. And these are the ways for the diagnosis, including the small bowel barium examinations, and the enterography and the enteroclysis, CT and MRI, endoscopic ultrasonography, and then CT angiography if there is the bleeding and so. Then the video capsules, which can be also used to locate the site of the lesion, radionuclide scans, and endoscopy, of course. Then polyps will be discussed in full details with the sector of colonic imaging. They are also common in cases of gastrointestinal bulbosis syndromes, and this is an example where you can see too many small filling defects or polyps in the small bowel. And in this case, you can also see some polyps as filling defects within the small bowel, and actually the detection of polyps may be difficult, especially if you don't use the double contrast study. One of the well-known bulbosis syndromes in the bowel is Budd-Sugar, and this is an autosomal dominant. One of the bulbosis syndromes, it includes many polyps in the small bowel, in the colon, in the stomach, and one of the characteristic findings in these patients is the presence of mucocutaneous pigmentations around the mouth, the fingers, and the toes. Polyps are usually hamartomas, and they are on the benign sector with a smooth muscle core, and they have no malignant potential. The Budd-Sugar syndrome seen in these pigmentations are seen in all patients by 2 years of age. These pigmentations are common around the mouth in 94%, in the hands in 74%, in the buccal mucosa in 66%, and in the feet in 62% of the cases, which can help in the diagnosis. As I have said, the polyps are hamartomas, and they are benign with no malignant potential. Sometimes the polyps are pedunculated, as you can see, and many times the polyps are very small without pedicles. Then the CT, especially after oral administration of contrast, may help to identify some of the polyps within the small bowel, and the presence of these pigmentations are very helpful in the suggestion of the Budd-Sugar syndrome. And here you can see in the terminal ileum 2 polyps in a case of Budd-Sugar syndrome. The complications include they are almost similar to the complication of any polyp anywhere in the gastrointestinal tract, including that the polyp will act as a head for an intussusception. It may increase the incidence of gastrointestinal malignancies and increase incidence of extraintestinal malignancy like the breast and the pancreas. The polyps can be seen in the endoscopy, like these masses within the bowel lumen, and all the gastrointestinal, the common bulbosis syndromes will be discussed in the sector of the colon, including dyscronchite Canada syndrome, juvenile bulbosis, and Codwin disease. And carcinoid tumor is a neuroendocrine tumor which is seen in the small bowel and also in the appendix. This tumor is slowly growing, but sometimes it can give metastasis. It can occur in the gastrointestinal tract, and also it can occur outside the gastrointestinal tract. Then carcinoid of the appendix account for 50% of all carcinoid tumors, and the terminal ileum carcinoid account for 90% of all small bowel carcinoid, while gastric carcinoid tumor is relatively rare. It represents only 0.3% of gastric tumors. Ovarian carcinoids represent 0.5% of carcinoid tumors. Bronchial carcinoid is about 1 to 2% of lung tumors, and carcinoid may occur also in the thymus and in the liver. And this is the case of carcinoid tumor with mesenteric lymphadenopathy causing occlusion of the superior mesenteric artery. This is the selective superior mesenteric angiogram showing the dilated collaterals. Once more, GIT tract account for 85% of carcinoid tumors, and carcinoid tumors account for around 2% of GIT tract tumors. And these tumors, carcinoid tumors, are characterized by increased serotonin production, and this scan, which is known as Octorio scan using indium 111, is specific to trace the site of carcinoid tumor as well as the presence of liver metastasis. Actually, the appearance of carcinoid tumor in the CT scan is not that specific, and you can see a mass within the abdomen intimately related to one of the bowel loops. And one of the characters is mesenteric retraction and the kinking of the bowel loops, which may be evident sometimes, but in many times it's not evident. Calcium can be seen in these particular types of the tumors, which are hypervascular and best appreciated in the arterial phase. And this is also a case of intestinal carcinoid tumor showing a mass which is related to the intestinal loops with relative thickening of the mesenteric fat planes, and you may say that there are some retraction or kinking maybe in the small bowel. And actually we may reach the diagnosis by imaging guided needle biopsy from these kinds of tumor, and this is the carcinoid tumor within the small bowel, and this is metastatic lymphadenopathy within the mesenteric lymph nodes. Adenocarcinoma of the small bowel is usually affects the proximal part of the small bowel, including the duodenum and the proximal jejunum, while the lymphoma is one of the tumors affecting the distal small bowel. Then diagnosis of adenocarcinoma by barium studies is usually difficult and depends on that the wall has an abnormal configuration with irregular outline, destroyed mucosal pattern, and sometimes narrowing of the lumen. But the use of CT scan can help in identifying the tumor mass and its relation to the small bowel, and if there is mesenteric lymphadenopathy as well. And this is a mass which is arising inside one of the bowel loops on the in the left lumbar area, and it has been proved to be an adenocarcinoma of the small intestine. Lymphoma accounts for 25% of all primary small bowel malignancies, and about 50% of all gastrointestinal lymphomas are located in the small bowel. And these are the predisposing factors, of course, the AIDS, the celiac disease, organ transplant, and H. pylori positive patients. Lymphoma is known to affect the small bowel without significant obstruction of the bowel lumen, without perforation as well, but is known as one of the causes of malabsorption. Then the radiographic features of lymphoma depends on long segment affection of the bowel, and many times you cannot reach the diagnosis from the barium meal follow through. You see here a long segment of luminal narrowing and another segment of luminal narrowing, and this can be easily mistaken for Crohn's disease, for example. But the long segment affection and the mucosal hypertrophy and the presence of bulky lymphadenopathy in the abdomen as seen by ultrasound or CT may help in the diagnosis. But if you see multiple polyps like this, they can be mistaken for bulbosis syndrome or any other disease which can cause hypertrophy and bulbosis in the small bowel. But knowing the patient had a systemic lymphoma, for example, or pathologically diagnosed by biopsy elsewhere in the body to have lymphoma, then you can reach the diagnosis. And you remember the lymphoma affects the distal part of the small bowel, especially the ileum, and the lymphoma causes long segment affection of mucosal mural thickening encroaching on the bowel lumen. One of the diagnostic features of lymphoma in the bowel is what is known as aneurysmal dilatation of the bowel lumen. And here you see this is one of the small bowel loops, and you see it's surrounded by huge mural lymphomatous infiltration. And if you look to this loop in the small bowel barium meal follow through, you can see evident dilatation, what is known as aneurysmal dilatation. And aneurysmal dilatation of the small bowel loop, like this one, is one of the features to suggest the possibility of lymphoma. And this is also by CT, aneurysmal dilatation of one of the bowel loops, and you see the lumen is also dilated, but the wall is markedly thickened due to lymphomatous infiltration. And here is lymphoma of the small bowel identified by long segment affection, severe thickening of the bowel wall, markedly encroaching on the bowel lumen. And this is also a case of a small bowel lymphoma affecting the terminal ileum, and you see the similar finding: long segment affection, significant mural thickening encroaching on the bowel lumen, and sometimes you can see a stranding of the mesenteric fat planes. هذا وبالله التوفيق والحمد لله رب العالمين.